Great. Thanks, John. Oh no, now I'm being recorded, so I better be careful here. So, I'm Mark Hurst. I'm a psychiatrist and addiction psychiatrist. Um, I've spent my career academic, clinical care. About half of my career was in state government, where John and I came across one another and worked on a variety of things in the early phases and middle phases of the opioid crisis, which we're still in. Um, And while I was in state government, I was medical director for the Ohio Department of Mental Health and Addiction Services. Then I became director of the Ohio Department of Mental Health and Addiction Services. And then I was also medical director for the Ohio Department of Health, including in the early days of COVID, which was a real interesting experience. Then I retired, or at least I thought I retired. And after a bit of time with that, I said, nah, I still need to make a contribution here. So I went back to clinical care, and I was medical director of the opioid uh, treatment clinic at Maryhaven in Columbus, that some of you are probably familiar with, which was a lot of fun. I'd always wanted to do methadone. I'm sorry, I should say, I always wanted to be a prescriber of methadone, never really wanted to do methadone. And so really enjoyed that and getting my hands back in it. Then I retired again and was unsuccessful at that. I recently heard the term nominally retired. I like that term, nominally retired. I think that's better than failing at retirement. So in name, I'm retired, but I'm doing a variety of things with consulting and medical education, including ECHO programs like this. Really happy to be here today. In reality, you guys know as much about polysubstance use as I do. So there's probably not going to be a lot new here. And, for Dr. Robbins, who was in another ECHO that I was participating in about a year ago, this is going to be probably repetition. I've updated the statistics and things like that, but it's pretty much the same kind of thing. So hopefully I'll have something that's worthwhile. I'd like to learn from everybody here too, and maybe we can have some great conversation at the end. So the first polling question is, how many of you have eaten some of your children's Halloween candy in the past 12 hours? There we go. How many of you have done that in the past? All hands go up, please. Yeah, of course. What kind of people are you eating your children's Halloween candy? You probably eat Easter candy too, and Christmas candy, and candy for other holidays. Dr. Robbins, I was happy to hear that you're up in Huron. I'm actually up in Huron part-time too. I've got a place up on the lake there that my wife and I enjoy going to. So maybe I'll run into you sometime at the hardware store there, or at what's the name of the restaurant? Berardi's. Maybe I'll run into you sometime up at one of those places.
Berardi's, it's a great place.
It is a great place. Yeah, it's very enjoyable. Well, let's get to the topic here and talk about people who use multiple drugs. Can everybody see that okay?
Yes.
Okay, great. And put things in the chat if you have questions, or interrupt me. All of that's fine. We're all here to learn from each other. I don't have the monopoly on knowing stuff about this. Again, you guys probably know as much or even more than I do with it. Okay. The objectives, we're going to look at the definition and the context of it, understanding the importance of accurate diagnosis, the impact of polysubstance use, and help folks with assisting patients who have polysubstance use. Well, let's start with a definition. National Council of Mental Well-Being says this: use of more than one substance or type of substance at the same time. I hope it didn't take them too long to come up with that definition. And it's good as far as it goes, but it really doesn't go far enough, because when we look at polysubstance use, we really need to look at a lot of different things other than just the presence of use of more than one substance, which many, if not most, of our clients or patients are experiencing. From a historical perspective, in DSM-3 and DSM-4, there was a specific category called polysubstance dependence, and it was described as use of 3 or more substances in a dependent manner without meeting criteria for dependence on any one of them. And it was eliminated in DSM-5. And it was eliminated for good reason. Polysubstance dependence kind of was a wastebasket term. That if you didn't want to do a thoughtful evaluation and somebody was using lots of different drugs and they were clearly having problems with it, you could put down polysubstance dependence. It was not an accurate diagnosis, but it was a diagnosis that was frequently used under those circumstances. So it really didn't have diagnostic specificity. There wasn't a lot of evidence that that diagnosis was meaningful. We like for diagnosis to lead to treatments. And if we have kind of this mushy term of polysubstance dependence, it's hard to determine what kind of treatment is really going to be necessary for this person. Now, in the old days, where we didn't have any form of medication treatment for substance use disorders, I guess with the exception of antabuse for alcohol, and everybody was referred to 12-step programs, I guess diagnostic specificity wasn't as important because it was kind of a one-size-fit-all approach. Well, it's no longer a one-size-fits-all approach, and that's why it's important for us to have diagnostic specificity. So it's not in DSM-5. It really should help us improve diagnostic precision, specific substance use disorders instead of this kind of mushy term. And that helps us delineate what things look like, what treatments we can use, and perhaps for prognostic reasons as well. So how important is it to have diagnostic precision? In medicine in general, it's very important. So, we use the term diabetes, we throw that around. It's in the vernacular in the public much more than it is in medicine, but diabetes can mean a lot of things. It can mean type 1 diabetes mellitus, it can mean diabetes insipidus, it can mean diabetes due to Cushing syndrome. All of those are under the term diabetes, but they all have different treatments, they all have different prognoses, so that specificity is important. If we move to another brain disorder of depression, that could mean a major depressive disorder, it could mean the depressed phase of bipolar disorder, it could mean depression due to hypothyroidism. Again, these are all different diagnoses under that moniker of depression, all requiring different kinds of treatment. And so it is with the term polysubstance abuse, in quotes, or polysubstance use disorder, which doesn't exist in DSM-5. A person might have fentanyl and cocaine use disorders. They might have alprazolam and alcohol use disorder. They might have alprazolam and cocaine use disorder. These are all different in different individuals and require a different therapeutic approach. So using a specific approach, not this kind of wastebasket term of polysubstance dependence or polysubstance use disorder, again, which doesn't exist, and sorting this out to the specific substance use disorders is of value. Well, how common is it? I don't need to go through this slide in great detail. We know that it's common. Is it the rule rather than the exception? Probably. In this particular study that came out of NSDUH, and they haven't looked at it in this way for a few years, so this slide is the most up-to-date that we have. And when we look at people who are heavy alcohol users, almost half use marijuana and a significant number use other drugs. Heavy marijuana, also likely to use other drugs. Opioid. I'm sorry, do we have a question? Oh, I thought I heard somebody. Okay, that's what I get for 7 a.m. presentations. Opioid, over half use marijuana, maybe more than that in our clinical practices. And methamphetamine, almost 2/3 use marijuana and about half use opioids. So, there's a lot of polysubstance use that's out there. It's important because polysubstance use puts our patients at risk for having worse outcomes. So when compared to a single substance use disorder, in those individuals for whom that exists, it's associated with higher rates of suicide attempts, higher rates of arrests, higher risk of incarceration, more financial and legal problems, more severe medical and psychiatric comorbidities. So we know anybody with a substance use disorder is more likely to have a psychiatric comorbidity and a medical comorbidity, but it's more common and it's more severe in people who are using multiple substances. And not unexpectedly, it's harder for people to adhere to substance use treatment. And there's an increased likelihood of overdose that we'll talk about a little bit more in a couple minutes. So this has been really evident during the opioid crisis. And I'm sure all of us have seen this slide about the evolution of the opioid crisis over the past 25 years or so. So we can see that in 2013, when there was the transition from heroin to fentanyl, of course, the more potent fentanyl deaths went up markedly. Lagging behind this, but only by a couple of years, is the rise in fentanyl deaths with stimulants. And that really parallels it up to the point where today, it's almost the same number of deaths with fentanyl lacking stimulants and fentanyl with stimulants. So these two substance use disorders, or polysubstance use, if you will, really demonstrate how lethal this combination can be. And we see that in Ohio too. This is looking at deaths due to cocaine and psychostimulants, which includes methamphetamine. This is the most recent, well, actually, it's not the most recent publication from the Department of Health about this. One came out yesterday, and I wasn't sharp enough to get this in the presentation today. But it shows pretty much the same thing, in that cocaine and methamphetamine, their lethality has stayed pretty much the same over the past 5 years. But when it's mixed with opioids, the rates go up substantially. Now, fortunately, in the past couple of years, we're starting to see a decrease in opioid overdose, lethal overdose rates nationally and in Ohio. So, it does seem like finally we're making a little bit of headway. We saw a decrease from 2017 to 2018. But then things went up from 2019 until the past couple of years. So we need to certainly keep at it with all the efforts that we're utilizing. Busy slide. I'm not going to go through this whole slide because it's very interesting. If you get a chance, you might want to get out your calculator and do some calculations. But if we just look at this last combination in unintentional overdose deaths, 64% of them in Ohio in 2022 were due to multiple drugs. So that really points to the lethality here. When we look at polysubstance use, we need to look at more than just does it exist. What's the intention of the use of multiple substances? What are the substances involved? And what's their timing in use? When we look at those things, that's going to help us better make a diagnosis and better help us put together a treatment plan that has an increased likelihood of success. So when we look at intent of use, why is it that people use multiple drugs? Well, one would be to modify the effect or enhance the effects of a single substance. Now, some of you are as old as I am. No offense, please. But you remember John Belushi dying from an overdose. And John Belushi had done a speedball, which is a combination of heroin plus cocaine. So that was to get more intense effect than he would have gotten with either of those drugs. Well, now we have like super speedball, which is a combination of fentanyl, more potent than heroin, and methamphetamine, even more potent than cocaine. So that would be an example of that. To compensate for the effects of one substance by taking another. You do too much stimulant, you're feeling a little bit edgy, you take some alprazolam to take the edge off, something like that, to prevent withdrawal symptoms. So you have been using opioids, you're starting to go in withdrawal, you don't have opioids available, you decide to take benzodiazepine to take the edge off. Of course, there's not cross tolerance between the two, but it does take the edge off a little bit for you until you have the ultimate treatment, which is to use opioids again to relieve that. Coping with the daily effects of trauma, life circumstances, other kinds of health problems. So people who mix and match depending on where things are with their mood in their life. I'm not feeling well, I'm feeling down, I do a stimulant. I'm feeling a little bit agitated, I do a sedative, those kind of circumstances. Maybe their primary drug just isn't available, so they're using any port in a storm. Or maybe they're coerced to use additional substances by an abuser. Not a primary focus of what we're going to talk about today, but human trafficking is real. And those who traffic people will use substances to maintain control over the individual that they are trafficking or that they are abusing. And that's a real issue. And then, of course, unintentional, which we see a lot of these days. A great deal of opioids are contaminated with stimulants, particularly methamphetamine. Many stimulants are also contaminated with with opioids. And of course, that is not intended by most people. It's intended by some, and makes the drugs even more lethal. So then, what are the substances involved here? Most of the literature that is out there is on marijuana alcohol combination or opioid and stimulants. There are so many different permutations, it would be hard to do meaningful research on all the different permutations. So the research has mostly been done on the most common. And most of these are naturalistic kind of studies. You couldn't do any kind of controlled study with these in general. So then when we do the evaluation, does the patient meet criteria for multiple substance use disorders, or do they just meet the criteria for one or two and they're dabbling with others? That has something to do, that has importance in terms of the treatment plan that we establish. Of course, we want to make sure that if they only meet criteria for a couple and they're dabbling with others, that those they dabble with don't replace the ones that they're stopping use of and become problems in and of themselves. And is there anything beyond the substances that meet criteria for SOD? Does any of that matter? Well, important to look at all the patterns of use of all drugs and their SUD diagnosis. Consider the relationship between their drugs of choice and the drugs that they use. Often we find that a patient is dependent on drugs that they don't see as a major focus. So they've been doing cocaine and they realize that that's a problem, but they don't realize how much alprazolam that they've been using to moderate the effects of the cocaine at different times. And they may be dependent upon that and at risk for serious withdrawal from the drug that they really weren't aware was a problem. And of course, that has implications in withdrawal management. And I didn't put it in here, and it's not really polysubstance use, but we do need to look at other kinds of addictions, particularly gambling disorder, because there's a significant overlap between substance use disorder and gambling disorder. And when individuals stop using substances, gambling can kind of creep in there and be a problem and lead them back to the substances of choice. What are the adverse effects of combining substances? There are a lot of them. I'm not going to read this here. With this group, I think that we're well aware of them. Mixing different kinds of stimulants like space basing and things like that, serotonin, all the augmented effects, anxiety, psychosis, depressants, more depression, lethal overdose, all kinds of things like that. And stimulants and depression, get cardiovascular problems and other things associated with that. Okay, question number one. One way to avoid opioid poisoning is to use a stimulant like cocaine or methamphetamine at the same time. True or false? Do we have a poll or do we just want to talk about this?
We can just talk about it, or we can have people raise their hands, but they would have to light up their cameras for us to do the latter.
Okay, well, why don't we just talk about it? You guys know the answer to this. I know you do.
I mean, they believe that it helps.
Exactly, which is the problem, right?
Right.
Yeah. So I would agree with that. Since we have people who are bashful, as we say in Zanesville, we'll just go ahead here. Of course, that's false. So the common belief is that stimulants can help stop the respiratory arrest that opioids cause. Absolutely not true. Of course, naloxone can do that, but stimulants can't. And then we talked about how stimulants are associated with increased opioid lethality in the past few years here. Okay, question number two. Which of the following increase the risks of toxicity when used in combination with opioids? Stimulants, alcohol, benzos, xylene, or all of them? What do you think, folks? You know what the answer is, right? And of course, it's all of them. So, any mixing of these drugs increases opioid toxicity, of course. Xylazine is a substance of increasing concern. It's kind of with us now. And it's another one of those things that is unintentionally a polysubstance problem.
Mark, we do have a question from the gallery.
Is it an easy one or a hard one, John?
Well, I'm going to defer to you on that. Could you please define space basing? Uh,
Yeah, I knew I shouldn't have used that term. Yeah, space basing was when people used, it was usually PCP plus a stimulant. But often it's referred to as mixing and matching different stimulants. Sometimes people would use a stimulant with a long half-life and a short half-life. But technically, it was the use of PCP. I guess in this era, maybe ketamine plus a stimulant, usually methamphetamine. Okay, xylazine. It's out there. Back in 2022, 23% of fentanyl powder and 7% of fentanyl pills, or so-called fentanyl pills, had xylazine in it. And the effects are like any other stimulant: sedation, decreased respiration, low blood pressure, slowed heart rate. The skin lesions are the things that are very dramatic. And here's what they use. And those of you who work in opioid clinics have certainly seen these kind of things. They are really, really ugly. Now, fortunately, there are test strips out there, not only for fentanyl, but there are test strips available for xylazine. You know, whether that will inhibit somebody from using a particular drug or not, you know, there's some controversy about that, but at least it gives them the opportunity to know what would be in their drug. The timing is important too. So are they using it at the same time? Are they using them one right after the other? Are they using different drugs in the same day, not immediately after, but in the same day? Or is it variable over an extended period? I'm using opioids for a while. I'm tired of that. I'm using something else. That doesn't seem to be as common to me. Okay, so here is, there are a variety of comments here that patients have made about using multiple drugs. So this is from someone who said, but if you want to go voyaging off into the universe, do a shot of crystal and special K or ketamine in the same shot. It's amazing. I don't know how to explain it. I feel like I've learned a lot about life in those kind of experiences. So it's a bit like space basing, since ketamine has such similarity to PCP. You know, that's one of the issues where somebody would be enhancing a high by using two different drugs. Counteracting the effects. I smoke the weed to control the Adderall. If I get too jittery, too uppity, and I'm grinding my teeth too much, okay, I need to smoke to calm down some and let myself know I got to go eat something. Or alleviating withdrawal symptoms. I kind of like to ride a stimulant wave. It's very typical for me to do after doing crystal all weekend, to just do Adderall to get through the day. Because again, you're not kind of cranky. You're still up. You're still awake. You're not tired. You're able to do superhuman things just by keeping going. So, you know, they realize they're probably not going to be able to do crystal all the time, although I would argue that eventually they do. So they do Adderall instead to kind of take the edge off, to still stay up, but not to be to the point where it's as problematic as it is with the crystal. Of course, in the evolution of a substance use disorder, that would become less and less common in most of our experiences. What about to prolong a high? I'd smoke crack and use heroin or fentanyl, what we call landing gear. Don't you love all these terms? To come back down. And once you get down, then you'll want to get another hit of crack to go back up. It's just like a cat chasing its tail. It never ends. Go up just to come down, then to go up again. So how do we address it? Well, primary care is important. Now, I realize most folks on this call are in the addiction medicine field. But in primary care is really important because we know most patients who have substance use disorders don't seek treatment for the substance use disorders. Some of them don't have access, and they are highly represented in primary care. Most OUD treatment is provided by PCPs, and the variety of things, substance use, mental disorders, general medical conditions, are often interconnected. And often patients present to their primary care with a general medical condition, which is either exacerbated by or perhaps caused by the substance use disorder. Integrated care is important, and delivering healthcare and mainstream substance use and mainstream health is an important thing to do. Now, this is a slide that appears every year in the NSDUH study, and it doesn't vary much. And I think all of us know this, that of the whole body of people who have substance use disorders, almost 37% in the United States, 95% of them don't see a need to seek treatment. Only about 0.5% do seek treatment, and about 5% or so think they should get treatment but don't seek treatment. So even if we provided perfect treatment to everybody, we're still going to miss the 95%. So primary care, doing screening, doing assessment, making referrals, helping people through stages of change, really an important thing. What kind of screening tools can be used? Well, as addiction docs, we probably don't use too many screening tools because by virtue of the fact somebody is in front of us, they're going to need a full assessment. But in a primary care practice, these are the ones that are probably best substantiated. The audit C, the concise version of the audit, which is 4 questions for alcohol, the audit itself, the single item drug screener, or the TAPS. The TAPS has the advantage of assessing for both alcohol and drug use. Now, NIDA says that alcohol is also assessed in the single item screener. As I read it, it's not. So if you're going to do all of these, the TAPS is one of the things that you can do. There's about a 5-question self-administered part for the patient. If that's positive, there's about a 10-question part for the clinician. It's a nice kind of screening tool, but any screening tool is better than no screening at all. One of the things that can be done in primary care, medical monitoring, which includes self-report, doing diagnostic testing, monitoring for infectious diseases, doing prophylaxis of infectious diseases when appropriate, doing pregnancy testing, prescribing contraceptives to avoid pregnancy in people who are actively using. All those things are great roles for primary care. Looking at their social circumstances of their drug use and continuing to work on their readiness to change for referral to formal treatment. Importantly, patients who use a lot of substances are at risk for undertreatment. They may get treatment for one, they may not get treatment for the other, they may not get treatment at all. And of course, their adherence to treatment has something to do with that. Withdrawal management is something that is really important in polysubstance use. People who are intoxicated and or withdrawing from 2 or more substances makes things really complicated, especially when there are varying time frames for withdrawal symptoms for each substance. So it's really challenging to do in the outpatient setting as a rule, and maybe best accomplished inpatient. So let's talk about a case here, and I really want folks' input on this. Patient comes to you, sick and tired of an addict's life, wants to get into treatment and withdrawal management as soon as possible. He reports use of fentanyl and clonazepam. So which one will result in withdrawal symptoms first? Which one has the greatest risk of life-threatening withdrawal? And how would you approach withdrawal management? So, folks, let's talk about this a little bit, because I don't have the answer here.
I'll take the easy one.
Okay, go for it, Chris.
The one that will result in withdrawal symptoms first is the fentanyl.
Yep. Yeah, and I mean, I appreciate you saying you'll take the easy one, because it's not easy, is it? How do you go about doing it? I knew you'd come to my rescue, Chris. Thanks.
So I'll help Chris out. The life-threatening is the Klonopin.
Okay. Yep. So how are we going to approach it? You're the doc on the withdrawal management unit. This is coming up. What are you going to do?
I mean, if I'm in a unit, for me, it's we're just going to clean you out of all of them. So,
Okay.
and then, I think, obviously, I think the hard part is, right, you gotta want to keep them engaged, and sometimes they're not ready for that in that sense. So it's like kind of working on what's the plan after I always say the detox is the easy part in my mind. It's the next day.
Yep. And of course, we have the patients who come into and I want detox, and they think that's the end of it. And we know darn well if you just detox people from opioids, their chance of success is no better than if you do nothing at all. And of course, this is unfair because it's two sentences describing this person.
Well, yeah, I was going to say I don't know enough about the clonazepam. Is that person snorting it, shooting it, taking it as prescribed? Are we talking about 0.5 of clonazepam from a prescription that that person has, or are we talking about street clonazepam, in which case it could literally be any drug under the sun? So the other thing I'm thinking about is I at least need a tox to make sure that the clonazepam is actually clonazepam. So
Yep, makes sense.
Mark, one of the difficulties I see with cases is there's a culture out on the street of users. If I can only get detoxed, I just need to clean my body and things will be fine. And there's a British study by Smythe that indicates with OUD users, a standalone detox exposure, unless it's immediately followed by a different level of care, has a 91% relapse rate, 64% within the first week. So we got to move away from this street culture that believes if they can only get detoxed. And I know with any of the benzos, a detox might only last, if it's inpatient, we'll say 10 days tops. But the insomnia that they're going to encounter is going to extend well beyond that. And that insomnia sometimes becomes their own personal crisis for relapse.
Yeah, John, you raised a point, and that was actually where I was going to go with this. I think that what all of us would try to do first is not to withdraw them from fentanyl, but try to induce them on methadone or buprenorphine and stabilize, what may well be the most lethal part of their disorder. Now, they may not be at a point to do that, but I would certainly try to get that to happen. So then I'm not going to worry about withdrawing them. And I'm going to feel a lot better in general if I have to do something with the clonazepam. And I would say if I have to do something, because clonazepam is a really long half-life drug. If they are using it as they say, it may well self-taper because of its long half-life, and I don't have to do anything with it. So if I have them on fentanyl, I can monitor how their withdrawal symptoms are on the clonazepam and see if I need to intervene with that or not. And of course, we know this combination is difficult because there's a lot of overlap in the withdrawal symptoms between sedatives and opioids. And they get the tachycardia, they get the hypertension, they get all those kinds of things. So doing it you could do it simultaneously, you could do it sequentially. In the old days when you had like lengths of stay that could be as long as you wanted, a lot of people would stabilize somebody on the opioid with methadone or something, withdraw them from the sedative, and then do that. That's really not practical in the current era. I think I would try to focus on stabilizing them, inducing them on buprenorphine or methadone, and then monitor the Klonopin. So lots of different ways to go with it, but it's tricky. I think all of us would agree on that. Okay, so withdrawal management is one thing, but what about the long term? As John said, just withdraw somebody from opioids. It's no better than doing nothing at all. So using medications for the longer term treatment makes sense. Now, we know for alcohol, we've got 3 FDA approved drugs, acamprosate, naltrexone, and disulfiram. For opioids, we've got naltrexone, buprenorphine, and methadone. And for tobacco, we've got varenicline, nicotine replacement, and bupropion. Those are the only ones that have an FDA approval. And we know that we use other drugs for other things which have data but are not FDA approved. So if we can use a medication, if we can hit more than one drug, if they're using more than drug with one medication, that's ideal. But if we can't, using multiple drugs is okay too, as long as they are compatible. So, you might think about naltrexone if somebody's alcohol and opioid dependence, or varenicline with alcohol and tobacco, because there is some evidence with varenicline having an effect on alcohol abstinence. Disulfiram and naltrexone with alcohol and cocaine. Actually, I probably wouldn't do that. I, as well as some of the rest of you, grew up in the era where all we had was disulfiram. And I used to use a fair amount of disulfiram, and I couldn't tell you the last time I used disulfiram. It's a hard drug. It's a hard drug for the patient to take. There are lots of interactions. I mean, it's not fun for anybody, and people don't stay on it, and they drink on it anyhow. About half of them who drink on it don't have a reaction. So it was approved in a previous era. If somebody had methamphetamine use disorder and, for instance, tobacco dependence, I would think about using the bupropion naltrexone combination, which there's been some recent evidence about it being helpful for methamphetamine use, particularly if they were alcohol dependent at the same time due to the effect of naltrexone. So, just kind of, see if you can use one drug. If not, mixing and matching is okay. Somebody's opioid dependent, alcohol turns out to be an issue too. Obviously, if they're on buprenorphine or methadone, you're not going to use naltrexone for the treatment of their alcohol use disorder because you're going to precipitate withdrawal. But you sure can use acamprosate, which I've done fairly commonly and have been reasonably pleased with the success of it. Okay, question number 3. People who are opioid dependent and use alcohol or benzos should not be treated with buprenorphine or methadone due to the risk of serious interaction. True, false, or it depends? I had to throw that "it depends" in there, didn't I? Which means that's probably the answer. Let's talk about that one a little bit. What do you think? You're treating somebody with buprenorphine, their drug screen's positive for diazepam. Lower the buprenorphine, read them the riot act, take them off it. What do you think?
I think there's no reason at all to take them off of buprenorphine. Keep it going and start lowering the benzos.
Was that Alan?
Yes.
I thought I recognized your voice. Yeah, I'm really with you on that. And fortunately, the DEA and the FDA are on board with that now too. Now, before just the past few years, if somebody was on a sedative, you really weren't allowed to continue to treat them with methadone, and that was a problem. And so there became recognition that it's okay to do that. It's not a contraindication. Yes, there's an increased risk of mortality with it, but in the end, the real increased risk of mortality is undertreating their opioid use disorder. So, I think we have to look at a lot of things. We need to look at how much they're using. Are they still safe to be treated on an outpatient basis? Are they using so much that we need to bring them in for withdrawal management while they're on the medication for opioid use disorder? Lots of complications with them. But yeah, it's acceptable. Yeah, it's tricky. If it's prescribed, of course, we need to interact with the person who is prescribing it. We need to see if there are other medications which could be effective for whatever the sedative is being used for. If they have anxiety, what's the root of that anxiety? Is it a real anxiety disorder? I mean, lots of different ways to go with this. But bottom line is, it's acceptable, but of course we need to look at it and be careful.
Mark, we have a question from Meredith Wiley that so many, and I'll just read it. So many of my patients drink on buprenorphine. I wonder if I'm lying and saying they shouldn't.
Well, I don't. Well, what do other folks think? I just won't pontificate here. What do you tell your folks with that?
I tell them to stop drinking. It doesn't hurt to tell them to stop. Some of my patients have actually said that once they started Suboxone, they stopped drinking and want to know if the Suboxone did that.
Yeah, I think that's a good question. I mean, I think many of us have had that experience. That once the opioid use disorder gets under control, the other things that they've been using are less appealing, and perhaps there is a genuine pharmacological approach to it. Easy to believe, since opioid antagonists are effective treatment for alcohol use disorder. So yeah, good point. Other thoughts?
Oh, this is. Oh, go ahead. Go ahead.
on the other hand, there are some patients that once we remove their drug of choice, they more eagerly lean into those drugs that weren't primary before.
Yep. Yep. Good point, John. Chris, you were going to say something?
Yeah, I was going to say, Meredith, I don't think you're lying in saying they shouldn't drink. My standard approach is anytime you're mixing two downers, you're basically asking for trouble. And so, what I would say, I mean, what I literally say in real life is, look, you're going to drink or not drink, regardless of what I tell you or don't tell you to do. All I can tell you is that there's an increased risk of adverse side effects if you're mixing two downers. So, proceed with caution. And if you want my advice, I would say, please don't be mixing alcohol with your bube. So.
Yep. Great points. Other thoughts?
Yeah, kind of same thing. I just tell them, hey, you run the risk of removing your safety features, bube, so you could stop. I just say, yeah, same thing Chris says. I think the interesting thing is, to everybody's point is, what I'm finding is there's a lot of things people are now doing, so it never just shows up on the drug screen anymore at all. So, you're seeing a lot more people using like whippets, dextromethorphan. If you're not testing for kratom, it's ridiculous how much, we just assume they say, yeah, I'm not using anything, and they're just clearly I'm not using anything that is identifiable.
Yeah. And patients are onto that, right? I mean, they know what's on our 7 panel and whatever other drug tests that we're doing. They know that unless we look for it, clonazepam and alprazolam are not going to be likely to be detected. And, they know all that stuff. I guess the other thing, of course, all of us are going to explore the alcohol. Tell me about the alcohol. What's that use all about? See what the circumstances are, see why they use it, see if there are other options for them other than alcohol, determine if they're dependent. Say I've got something that may be helpful for you with that, like a camprosate. So, just continue to try to work on them. This is still a bit of a hangover from, no pun intended, a hangover from our absolute abstinence days in some ways, that, you need to not use anything. And, these drugs for opioid use disorder are kind of dirty drugs, and, it's not real recovery. And if you're using something else, it's certainly not real recovery. And I think and hope that we're evolving with that and understanding that alive is good, and buprenorphine and methadone keep people alive and give us an opportunity to continue to work with the other drugs too. So I hope we're getting there. I think we are. But, I think in general, the public needs to understand medications for opioid use disorder reduce harm, but are not pure harm reduction, like syringe exchange programs and things like that, which I think are excellent also. So we get back to the diagnostic specificity here. This is great discussion. Thank you so much. So for the psychosocial treatments, some of them are demonstrated to be helpful for different drugs. Just because there's not an X here doesn't mean that it's not helpful. What it means is it really hasn't been studied. But that can help determine what kind of therapy people will be getting. Now, in reality, there aren't a lot of people who have great expertise in all these different forms. So they're probably going to utilize the ones that they're most familiar with. And, I think that's fine. Of course, it doesn't depend also only on the drug. It also depends upon where they are in their stage of change, because motivational enhancement therapy or motivational interviewing are helpful in moving through the stages of change, regardless of the substance. Okay, what about harm reduction? Particularly in primary care practices where they may not be providing specific treatment for the substance use disorder, educating people about harm reduction, helping them stay alive is a good thing. And all of us know these things. Don't use alone. Carry naloxone. Be sure your friends have it too. Test the drug before you use it by dipping the test strips. Have both fentanyl and xylazine test strips. Use a test dose a little bit that you intend to inject or inhale. Although I think it's really hard for a patient who's in withdrawal using a test dose and then saying, oh, yeah, I don't think I'm going to use it after all. I mean, they're going to want to relieve that withdrawal. Okay. Should tobacco be considered part of a polysubstance use pattern? Yes or no? Help me out with this, guys. What do you think?
I would say yes.
Yeah.
Yeah, so what do we think? What do I? Yeah, I think so. And why? Well, more patients who smoke drop out before completing treatment, however completed treatment is defined. Individuals who smoke, both new smokers, people who continue to smoke, and those who have relapsed, are twice to 5 times more likely to relapse to other substance use disorders than non-smokers and never smokers. And smoking cessation, including active nicotine management, should then be part of SUD treatment. But, it's really hard, isn't it? And, a lot of facilities have said, we're a non-smoking facility, and they've found their patient census plummets, that the patients aren't wanting or willing to deal with both of them. But I do think people really should be presented with the evidence that you're less likely to do well if you continue to smoke than if you don't, and we can help you with that. And then it's an individual decision on their part. E-cigarettes, more of a deal. Also, this is with adolescents. 12% of adolescents use e-cigarettes. And of those who use e-cigarettes, about 11% use other substances as well. That would actually be half of this when you look at the total number. So this isn't just that. So, most don't use it, but those who do use it will use both. We use other drugs. And the most common is to use a whole cadre: e-cigarettes, alcohol, cannabis, and tobacco. So we need to ask about e-cigarettes and try to minimize e-cigarette use, particularly in those kids that are in a vulnerable age for development and evolution of a substance use disorder. And the most common drug first used by young people, nicotine vaping. So it's something we really need to keep a point on. So getting to the end here. It's common to use multiple substances. It's associated with more adverse outcomes. The diagnostic precision is really important. And I think that, to me, is the takeaway from this. Make sure we diagnose the disorders that are there so we can tailor treatment appropriately. Primary care providers are important. Screening tools are important. All of the usual treatments should be considered, mixed and matched in order to meet the needs of the patient, based upon disorder, based upon stage of change, based upon treatment provider expertise, based upon patient preference. MOD can be utilized even in the face of sedative or alcohol use, and tobacco use should be considered as part of a substance use pattern. So that's about it. Got some resources for you here that are available on the slides. And I will just wrap it up there.